So, I mean, I hope the discussion and, Ralph's lived experience shows how important mutation testing is in terms of risk stratification, in terms of diagnosis, and in terms increasingly of identifying the best treatment. I just in that context want to say that that applies not just to trial treatments, but it increasingly applies to standard of care. If you have a FLT3 mutation, you should have a FLT3 inhibitor with intensive chemotherapy. That there are different mutational testings methodologies available for AML. And it's very important when we're thinking about different methodologies about the question we're asking. More sophistication doesn't necessarily help if the questions that need answering are quite simple. And finally, I think it is this spirit that we talked about with Gail just now. And, I think the wonderful example of how Gail and Ralph and his family had this lengthy phone conversation about what was the best treatment for Ralph. Physicians really do want to engage with patients. We are your servants. And I think an open conversation in which patients can identify concerns they have, ask questions that don't make sense, and perhaps using those discussions move towards the best treatment for patients is important. And it's for that reason that I think in the clinical trial context, we would be discussing options with patients, but then encouraging patients to go home for a few days, write down any questions they have, and then think about moving forward. So next slide, please. These are just some references that you may find useful. But I wanted to use the next few minutes, as Gail suggests, to pick up some of the questions that we have received. And I'm going to probably just put them out in the first instance, to Gail. And I think, Gail, I wanted to just really pick up this question about how long should you wait when you've got newly diagnosed AML for the relevant genetic tests? It's a nuanced answer, I'm sure, but perhaps you could address that.
Yeah, I think that so the reason that Charlie is using the word nuanced is the following. So when I went to medical school, it was still the case. So it's not, 100 years ago. I'm not that old, but it was enough years ago that we always said, and this was the quote that everybody had, that don't go home without starting treatment on a new AML. Don't let 5 o'clock go by without starting. So AML was taught to us as a medical emergency to be treated immediately, really without exception. It was an emergency diagnosis. And the reason for that was, honestly, there wasn't terribly much therapeutic choice to be made. We had a couple of hammers. The patient was going to get one of two choices of hammers, and there was no advantage in waiting. Over the years, there was an absolute windshield wiper from that scenario to absolutely wait until the genetic information comes back. So we went from treat immediately, don't wait, don't even go home, to stop. It's safe to wait for the molecular, genetic, and additional information to come back because that's going to dictate your treatment. And the answer, like most of life, is not windshield wipers. It's somewhere in the middle. And very specifically, there are absolutely patients who are coming in under emergency circumstances where you must move forward because there is not an advantage to the patient to hanging around waiting. You need to start treating the disease because bad things are happening. In addition to that, the therapies are such that you may have an opportunity to pivot when your molecular genetic information comes back. So there are treatments now that you can get started promptly if you think it's clinically wise for the patient to get moving. And then you might make a pivot when the genetic information comes back. And the third category is there are absolutely patients where as the treating team, that your treatment would be quite different if you knew the molecular genetic information and the patient is sitting around stable. So we do wait and we say to the patient, you're going to hang out, we're going to wait. And the reason for that is because if I get back result A, B, or C, it's actually going to be a very different discussion. And I think it's important to keep my windshield wipers in mind, because I never say it's perfectly fine to wait. I never say it's absolutely necessary to treat immediately, because it's usually, honestly, somewhere in between those, with the exception of the true emergencies. And the other exception is acute promyelocytic leukemia, which is a different subtype of AML, which is absolutely an emergency and must be treated right away.
Fantastic, Gail. So I think perhaps we're drawing to our close. So in the last perhaps 2 minutes, Ralph, just some kind of concluding remarks, perhaps followed by Gail's. Over to you.
Well, as I've expressed, I have a feeling of gratefulness. Never expected to be here these 10 years. I remember now, before I got the diagnosis, I was starting to feel older. And later on, Dr. Roboz and I discussed that. She said, just because you're 70 doesn't mean you have to start feeling older. So my message is try to get to the best doctor you can whenever you have an oncology doctor that you need. I was very fortunate to do that. The idea of testing and then deciding, I think Dr. Craddock's comments was a good one. Get the mutation testing now, because you may not need a clinical trial. There's so many new standards of care that are out there. So the whole thing is, what do I do here these last 10 years? Maybe making a speech or doing a Zoom call. I'm not a physician. All I can do is be an example of hope, and I'm just grateful to be here.
Thank you, Ralph.
You are the perfect example of hope. I just wanted to say how great it is to be able to have webinars like this, but specifically with you at our past 10-year anniversary. I saw that there were some questions coming through with clinical information. Just for anybody on the line, we never do clinical cases on a call like this, because only a dopey doctor would answer that without lots more information. And neither Dr. Craddock nor I are in the dopey doctor category. So please reach out if we can help you with clinical information, or reach out to your treatment teams. And thank you so much to the organizers for inviting me, and to Charlie for inviting me to join this fantastic hour.
Yeah, so I've also just been inspired, really, Ralph, by your story. It's such an exciting time for extending effective treatments that were only dreamt of 10 years ago, which are now standard of care. But they establish really the bridgehead that we should be more ambitious now in thinking about targeting through new drugs or transplant effective treatments for as many patients as possible. And finally, to pick up on what Gail was saying, is we have to remember the great difference between chronological and biological age. There are many fit patients up into their late 70s or early 80s who are absolutely fantastic candidates. They're actually in their 70s for transplant or for these innovative therapies. So I think we need to do away with age as a barrier and think about serving our patients to our best abilities through the networks of clinicians and patients that we've referred to. So I want to just conclude by thanking all of the participants, or all of the delegates, and thanking NoML for organizing a great session. I hope you all have a great evening.